Welcome, everyone. Good morning. Thank you so much for all of you being here today with us. My name is Niambi Cooper, and I am the director of ONEgeneration Senior Enrichment Center here at ONEgeneration, led by our president and CEO, Jenna Haas. So the layout of our presentations for today, they're going to be composed of having the presentation first by our speaker, and then the questions and answers will be at the end. So please feel free to use the Q&A chat box at the bottom of the page, and we will for sure answer your questions at the end. So today, this presentation is being recorded, so you can have access to watching it again from our ONEgeneration newsletter. If you do not receive our newsletter and you would like to receive that via your email, you can give our office a call at 818-705-2345. And today we have Andrew from Dynamic Hospice Care, and he will be presenting on what is hospice. So welcome, Andrew. How are you?
Thanks, Niambi. I'm good. How are you doing?
Doing good. We're so excited.
I'm excited also. Thank you so much, and ONEgeneration for having me on here to be able to talk a little bit about hospice care. Again, everyone, good morning. My name is Andrew Akbo. I am the Transitional Care Coordinator for Dynamic Hospice Care. And today I'm going to talk a little bit about hospice and what it involves, who's involved, and what are some of the benefits of this higher level of care. So, what is hospice care? And everyone pretty much has a little bit of idea of this type of care. It is end-of-life care, but our main goal under hospice is to provide comfort in all aspects for your family member, for your loved one, for your friend. We want to be able to provide comfort because they are dealing with a terminal illness, and we want to be able to support them in all aspects, not just the physical ones that they're dealing with the diagnosis that they have, but mentally, emotionally, spiritually. We want to be able to have this holistic approach because it is end of life, and it's just not a one-dimensional type of care, and it's also a very unique type of care. But our main goal is to make sure that your loved one or the individual is able to not only live the rest of their time in dignity, but to be able to be comfortable and just to be able to live a higher quality of life at this point, as they spend the rest of their time with you, the family, and everyone else. So, I want to start off by just kind of talking a little bit about what factors make an individual appropriate for hospice care. Before I begin, I just want to let everyone know that my role over at Dynamic Hospice Care is kind of a family liaison. So I help transition care. I sit down with the families, I contact them directly, schedule those appointments, and basically be a resource for them, and to provide as much information to answer the questions as much as I can, because there is a lot of aspects to hospice care, and there's a lot of details that come with it, and it can get overwhelming at times. So my role is to be able to sit down and answer those questions for families. It is a non-clinical role, although I do know a lot about the common diagnoses that most of our patients have, what factors and comorbidities our medical team looks for. But when it comes down to a lot of the clinical aspects of hospice care and the overall care, I leave that to our team. So our medical team, I'll talk about who's involved later on, but they would be primarily the ones that would be talking about these next couple scales that I'll go over, and they'll have a better idea of it. But I would just like to share a couple of them with you today. So Again, criteria for hospice care, any patient or family member that's diagnosed with a terminal illness and has a life expectancy of 6 months or less are appropriate for hospice care. Another thing is that they may be no longer seeking aggressive treatment. For example, if I'm working with a cancer patient and they decide to discontinue chemotherapy, then at that point they would be appropriate for hospice care. Some common diagnoses that you see with patients under hospice care would be people with Alzheimer's or dementia, people dealing with cardiac issues such as congestive heart failure, liver disease, such as cirrhosis, renal failure, cancer, and neurological disease. So these next couple of slides are some scales that are used by our medical team to help identify if that certain patient or individual is appropriate for hospice care. And these first two are the KPS and the PPS. The Konarski scale, which is the KPS, it basically outlines functionality and performance by the individual. So per my director of patient care, he says that they usually look at the very bottom portion of this scale, which is number 40 and below. And in those categories, it says unable to care for self, requires equivalent of institutional or hospital care. Disease may be progressing rapidly. So, this scale kind of just looks at the overall function of that individual and if they fit within the number 40 or below. The next one is the PPS, which is called the Palliative Performance Scale. Again, it's a functional scale that's used by the medical team, and you're looking at number 40 again. So the first column is 40% and below. Each column is ambulation, which is how much they're able to move at that point. At 40, it's mainly bedbound. Activity and evidence of disease, self-care, intake, which is food or liquid intake, and conscious level, if they are alert, confused. These are all considered functional scale that our team looks at. The next scale is called the FAST scale, and that's used for mostly Alzheimer's and dementia patients. And our medical team looks at number 7 at the very bottom. A through F, there are a couple factors that they specifically look at as far as speech, if they're able to say a certain amount of words, how are they able to, or how are they moving? Are they bedbound? Are they walking? Do they have the ability to sit up or hold their head up? These are certain indicators that would categorize an individual to be appropriate for hospice care. Now, this scale might be combined with one of the other two in the beginning as far as functional and Alzheimer's dementia. Sometimes they use the scales in conjunction to each other to make sure that the individual qualifies for hospice. And then one other scale that we use is called the New York Heart Association classification. And usually if an individual is in the class 3 or 4, they would be appropriate for hospice care. They would also be considering any other comorbidities that would be involved with their condition to make sure that they're appropriate for hospice care. Okay, so who's involved within the team? So I'm just going to go clockwise with this picture here. The first one is a registered nurse at the very top. So, you'll have weekly visits by a nurse coming in. A registered nurse usually initiates the care. So say for example, I sit down with the family. I'm the very first point person at the very beginning talking about benefits of the care and then who would be involved. And then after that, our registered nurse would come out and see the patient and the family. They would do their initial assessment. They would go over what medications they're currently on, assess the house or the room, and see, if they can fit a hospital bed, or what supplies they need to be ordered. And then they would do their evaluation on the patient themselves. After that, they would report, their assessment to our medical team. Follow-up visits may be done by a registered nurse, or we send out a licensed vocational nurse, which is an LVN, to visit the patient on an ongoing basis, whether it's once a week, 2 times a week, or 3 times a week. So there's always a medical clinical person coming to see you at your home. Each visit is typically about an hour, a little over an hour, depending on the needs at that moment. The next person on our team is a medical director. So every hospice should have an in-house physician or a medical director. They are pretty much the person that is making all the decisions as far as healthcare at this point, whether it's maybe a change in medication or a change in frequency of clinicians visiting. But they are the person that are making most of the critical decisions. Now, individuals or families also have the right to choose their own primary care physician to oversee the care. So, as Dynamic has their own in-house physician that will oversee the care and is offered to a family if they want our doctor to be the lead, but they also have the choice to choose their own primary care physician. So, I just want you to know that if you are a family member or someone that's inquiring about hospice care, you have the right to choose your own doctor at that point. Okay. The next one is a chaplain or a spiritual counselor. Again, they are there for spiritual support. They would be visiting at least once a month at the least. And, you can always have them visit more often. Every hospice should have a couple chaplains on staff to accommodate your religious beliefs. So there should be a couple of different spiritual counselors that can come out and see you. The next one is a home health aide, and they're basically coming into the home to see the patient to provide bathing. So, they come in, whether it's helping transfer into a shower or just a bed bath, and then they also help with applying creams or any personal hygiene that needs to be done for the patient. Next one is volunteers. Right now, through COVID, volunteers were a little tough to get within the home. Sometimes we would do maybe a Zoom visit with a volunteer, but with COVID, we weren't allowing or weren't having volunteers go into the home just because the families were a little bit uncomfortable if they weren't a necessary visit. But they are there for additional emotional and mental support, because it's nice to just have another person to sit down with and talk with, maybe take your mind off the current condition of the patient, and talk about the weekend, talk about what's going on in the world, and just to have someone to talk to or even listen to. The next one is the patient physician. So this one could also be categorized as different specialties or disciplines. What I mean is that sometimes in their hospice care, there's a need to bring an outside specialty in, whether it's a wound care specialist to help with, bed sores, or if someone's having issues with their feet or toenails, we can also order a podiatrist to visit the home. If necessary, we may need to send out IV or X-ray or anything like that. So, there is a need for outside vendors or outside, physicians or specialties to come into the home, anything to provide that comfort for the patient. And the last one is a social worker. So this team member is important. Most families usually ask me, hey, Andrew, what's a social worker usually used for? And I say that they're a great resource and a great extra helping hand for external, problems or issues, whether it's the patient and the family's finances that need to be addressed. Another good thing that social worker can help with is if you don't have a advanced care directive in place, or going over a PULSE form, which I will talk about briefly about in the next slide about those two forms. But they also help with mortuary setup. I tell my families to use them because they are available to them, and it doesn't hurt to ask what they can help with. If it's something that they can help with, great. If it's not, then they'll definitely lead you in the right direction. But they're there to make sure that you, the patient, and the family aren't dealing with this by yourself. So those are basically your team members, and then you'll have a director of patient care that's not listed on here, but that person usually oversees all the nursing and coordinates with the doctor or medical director and help with the plan of care and ongoing healthcare decisions. And then you have me. So the last person of the team would be me, a non-clinical family liaison or transitional care coordinator, basically to help ease the process for the family. Because like I said, there's a lot of things and a lot of aspects of this type of care that are involved. So it's always nice to have maybe just one person to reach out to if it's a non-clinical issue to be able to address certain things. So as I mentioned before, the advanced directive and PULSE form. So these basically outline your healthcare wishes. And I always suggest to families, if these aren't in place, to make sure they start thinking about it, they start reaching out to our social worker to work on it, because it's not only less stressful to know your loved one's decisions, but it's also easier for the healthcare team to know what to do in certain situations. So on the left-hand side is your California Advanced Healthcare Directive. And, within this directive, you're assigning a power of attorney. You're going over healthcare decisions based on life-sustaining protocols, whether you want CPR or not, whether you want feeding tubes. These things are addressed in the healthcare directive, donation of organs, and these things are all kind of determined within this healthcare directive. The other form is the physician orders for life-sustaining treatment, which is the PULSE form. It's the bright pink form. This one is usually left inside the home in an area that the emergency team or our team can see clearly, so we know what to do in case of a situation of distress. The first three sections of it, A, B, and C, they talk about CPR, medical interventions, and nutrition, whether you want feeding tubes or not. These two forms should be complementing each other, or at least in line with each other as far as wishes. They shouldn't be contradicting each other at all. But it is important to have both and not just one or the other. So the additional benefits of hospice care is you'll have three benefits, main benefits here, along with the team members that I was talking about earlier. Medications. So all medications will be covered under the hospice benefit and would be delivered directly to the home. So like I said before, with the registered nurse doing her evaluation and taking down all the medications, this is where we would take down all the medications that the patient is on, and then we would order everything through our pharmacy and send it out to the home. The next thing that you would have available to you and for our patients is medical equipment or supplies. And some examples are a fully electric hospital bed with a low air mattress, oxygen concentrator, some oxygen backup tanks, maybe a commode, shower chair, ambulatory devices. Usually, whatever needs to be brought to the home or delivered to the home, our equipment company would have it. And then medical supplies. This can range from incontinence supplies such as diapers or chucks to gloves, even Ensure is provided. and some personal hygiene creams. But the equipment and supplies, we usually let the family know, reach out to us, let us know what's running low, let us know what you need, and we would send it out. And again, just like the medications, they would be delivered to the home also. And lastly, you have 24/7 on-call availability. So, usually you would have a folder within the home and a number on that folder, which would contact us directly, whether it's through our office during the week, during work hours, or after hours, you'll be connected to our on-call nurse. And that person would be able to answer any of your questions over the phone, whether it's, how do I use this, oxygen concentrator, or, my loved one or family member needs this type of medication. How much should I give them? You'll always have someone to talk to on the phone to be able to provide that extra support. And if necessary, in certain emergencies, you can request our nurse to come out in person. And that can be in the middle of the night, that can be over the weekend, that can be on holidays. So just know that under hospice care, you have that support 24/7. And then I would also say that we can schedule our medical director or in-house physician to also visit the home. If it's, you're choosing your own primary care physician to oversee your care, we would have to contact them and make sure if it's okay for them to go visit. But our in-house physician is always available to make a home visit if necessary. And just the last part I wanted to kind of go over is the 4 levels of care of hospice and who pays for it. So for the 4 levels, the most common is the regular routine care, which is done usually at home, or what the patient determines home is. So it could be an assisted living facility, it could be a boarding care, but typically it would be in their own home. So that would be routine care. We would have our clinicians coming weekly. We would deliver all the equipment and medications, and everything would be provided, all the care would be provided at home. General inpatient would be a scenario where we would have to send the patient to a hospital because it was a situation that we were unable to handle at home, and we need extra support. So we transfer the patient into the hospital. The next type of care is respite care, and that usually is focused for the family members or the caregivers that are providing a lot of the care for the patient or family member. And this type of care is to relieve that family member or caregiver. Usually we would transfer the patient over to a facility for a few days and give some relief to the primary caregiver. And lastly, continuous care. Continuous care is usually used or initiated during distress. So say we're providing regular routine care in the home, and a family member might be declining rapidly and starting to go into a distress. We would start continuous care, which would be basically sending out a nurse to be bedside for several hours to be able to monitor, administer medications if necessary. But that type of care is usually used, near the end, and to make sure that the patient or family member is comfortable. There are times where continuous care is initiated, and then the nurse will leave because the situation has been handled and controlled at that point. But typically, you see continuous care being initiated near the end. And who pays for hospice? So 100% is covered, all services, by Medicare and Medicaid or Medi-Cal. It depends on the state, but hospice care benefit is 100% covered by Medicare. And then there are some HMO plans and private insurances that do have a hospice benefit that would be covering these services. It would just be necessary for the agency to kind of verify that insurance and see what's covered. But for the most part, when it comes down to hospice care, Medicare is covering it 100%. So that's just basically the overview of hospice care. The next few slides are just talking about our agency. So again, I work for Dynamic Hospice Care, but Dynamic as a whole provides 3 different home care services: home health, hospice, and caregiving. The one thing I do want to add to this presentation is that for hospice, just know that we're not there in the home 24/7. So if there isn't a family primary caregiver or a private hired caregiver, I usually recommend families to have one because our clinicians come in weekly, but we're not there for the whole day. So it's always important to have someone there with the patient or the family member to make sure they're also, monitoring and making sure everything's okay and be able to contact us if there's any issues. So, it's really important to have a caregiver also hired or at least a family member with the patient. But anyway, Dynamic, our company as a whole, we provide these 3 services. We've been servicing the LA area for over 30 years now. We are a home health provider, preferred provider for Cedars-Sinai. We work in a lot of areas. We start from Santa Clarita as far west into Ventura County and as far south down towards South Bay area. And we usually have clinicians in all these areas to be able to accommodate patients depending on where they live. And that's pretty much it. Again, we provide home health, hospice, and caregiving. My contact information is in the bottom right. Again, my name is Andrew Akpo, Transitional Care Coordinator. My direct number that is there, it's 818-573-4491. I hope you guys were able to take some information and learn a little bit more about hospice care. And if you want to ask more questions or anything, you can always reach out to me.
Thank you so much, Andrew. That was an awesome presentation. Does any of our attendees have any questions for Andrew? Feel free to use the chat box. We also have the Q&A box at the bottom part of your screen, or you can just raise your hand and I can allow you to ask us a question verbally. So if there's no questions, like Andrew said, feel free to take down his number that he has present on the slide. Also, if you have any questions just about this presentation with Dynamic or any of the presentations or questions just about resources, of course, you can give us a call at ONEgeneration. I can put our telephone number in the chat box and you can just give us a call and we can direct you. Thank you guys so much. Thank you, Andrew, just for coming on this morning and just giving us so much information, just overall what is hospice care and just the in and out of it, because it's really in detail and it's a tough time. So it's really helpful. Just everything that Dynamic does and just your position as well.
Yeah, you're welcome. Thank you so much for having me.
Thank you.